Yes, okay.
Okay, thank you, Professor Ogawa. Hello, everybody. Good morning and good night. I am PY Dr. Peng Yun Zhou. Thank you for your participation in ICC. This is our 20th ICC webinar. In the first of all, I would like to pay my gratitude and say sorry for all the participants in our Chang forum, which was just held 1 week before. I really appreciate all for your join in our webinar Chang forum. And next week, next Sunday, we will replay our recording of Professor Yurei Chen and Professor Daniel Wang's video for the compensation in the loss in the first day. Okay, today we are so happy to have Professor Ogawa with us. Professor Ogawa has the MD and the PhD degrees. He is currently the professor and the chief at the Department of Plastic, Reconstructive, and Aesthetic Surgery at the Nippon Medical School in Tokyo, Japan. Also, he is a visiting lecturer at the Department of Plastic Surgery in Tokyo University. He is now directing the mechanobiology and mechanotherapy laboratory at his medical school. He joined the tissue engineering and the wound healing laboratory at Brigham and Women's Hospital, Harvard Medical School, between 2007 and 2009 as a researcher fellow. Professor Ogawa was the recipient of several awards. For example, the award of Japanese Society of Plastic Surgery and the many research grants. He has co-authored over 50 chapters in books, co-authored over 400 more papers in scientific journals, and has presented over 1,500 more co-authored papers at conferences, including over 250 invited lecturers, including today's webinar. So I can't wait to introduce and welcome Professor Ogawa give the great lecture with us. So let's applause and welcome Professor Ogawa, please.
Thank you very much for your kind introduction. At first, I'd like to thank Dr. Tsai and colleagues for giving me this opportunity. And my talk will not be just about craniofacial surgery, but I think it's helpful for every kind of surgeon. So I'd like to start my talk about scars and keloids. So I have organized scar and keloid clinic, specialized clinic, since 2006. The now new patient is around 2,000 in a year, and all over Japan, the patients come to our hospital. So keloid hypertrophic scars, contractures, mature scars, many types of scars we have treated. And also Dr. Tsai joined our clinic. So actually histopathology of hypertrophic scar tissue, the inflammation can be found in the reticular dermis, so deepest layer of the dermis. The keloid is similar, but we can see keloidal collagen. This is very characteristic structure in keloid tissue. And but the inflammation is very strong compared to hypertrophic scar. So actually, the amount of dermal nodules and the keloidal collagen are different between typical hypertrophic scar and the typical keloid. So we believe difference of strength and or duration of inflammation exist between two types of scars. So actually, there are favorite sites of keloids. The keloid have actually the easy to occur on the anterior chest wall, upper arm, and the suprapubic area. This area is frequently stretched. So we have interested in the relationship between mechanical force and the keloid development. So keloid is always stiff and the adjacent skin is soft. So when we stretch skin this direction, always this this area is very stiff, so cannot release tension. So soft skin adjacent to the keloid sense too much mechanical force. So clinical appearance is clearly matched. So high tension area, the inflammation continue and become strong. So to treatment and the management, including every kind of surgery, conservative therapy, it is important to release tension. So the very interesting things is also unfavorite sites exist. The parietal area and the anterior lower leg and the upper eyelid. So please try to stretch your skin on the scalp. It is very difficult. This means the very large bone exists immediately below the skin. So it is already fixed. So even if inflammation occurs on the cranial area, the tension, so inflammation cannot be continued because already stabilized. So this area, actually it is easy to cut and suture, but we don't need to carefully, we have to suture. But these also, the anterior lower leg is same situation. Bone exists immediately below the skin and difficult to stretch. So this area is easy to do surgery. And also upper eyelid, when we close eyes strongly, open eyes strongly, there are no tension on the upper eyelid. This area, inflammation cannot continue. Okay, so these patients have a body constitution of keloid, but there are no keloid here, no keloid, and no keloid on the upper eyelid. So inflammation cannot continue in this area because this area is completely stabilized. So actually characteristic shape of keloids are determined by skin tension, we believe. So releasing tension is very important. So always the skin tension line direction is equal to the muscle fiber direction. So in case of abdomen, it is vertical, and in case of chest wall, it is horizontal. And that today, please keep in your mind very important things is that all suture wounds are temporarily become stiff because collagen fibers are produced and adhered. So it looks like an image of making a hard string. Every kind of surgery, such kind of hard string will be produced. So for example, abdominal surgery, the hard strings is developed by surgery, and the patients, the ADL increase after discharge from the hospital. The always tension occur this direction. The abdomen is pulled up and down. And first, the string itself causes inflammation. This will be a reason of development of hypertrophic scar. Okay, and that every day the patient moves, inflammation continues and becomes strong. So inflammation spread to the surrounding skin when stronger force is applied. So this will be a cause of keloid. So this patient has a string, you can see, looks like a rope. And this area cannot release tension. So inflammation spread to the tension direction. This is the reason why the keloid shape looks like this. This is the strings. So such cases, segmentation is very important. So hard string exists. So we cut like this. This is Z plus T. And immediately after surgery, zigzag line wound is produced. 3 months after surgery, actually the string becomes 1/5. So segmented to 5 pieces. And tension, each tension decreases. In the result, 6 months, 1 year after surgery, tension decrease, so inflammation decrease, and the maturation is accelerated. Okay, so the incision line should not be matched to the skin tension line because hard string will be produced and tension cannot be released. So if the incision line is 90-degree different from tension line, tension becomes smaller and reasonable. So prevention and treatment of keloids and the hypertrophic scar, there are 2 points. One point is that we have to do not increase inflammation, and at once inflammation occurs, we have to try faster convergence. Faster, we have to make inflammation smaller. So, for the purpose of don't increase inflammation, so we have to define surgery, and post-operative care, we have to think carefully. So at first, I'd like to talk about surgery. So this is a nevus and simple removal and just suture. So in this case, it is very important things here. Don't pull wound edge with dermal suture, because keloid and hypertrophic scar is a continuous inflammation of dermis. So if we want to close this wound, if we suture dermis sense mechanical force tension, and it becomes a hypertrophic scar. So we have to suture fat tissues. It is very important. And after that, naturally wound edge is attached. So at that time, finally we can start dermal sutures. Okay, so we cannot use dermal suture as a tension reduction sutures. So what tissues? This is an ultrasound. This is fat layer. You can see superficial fascia like this. This is white membrane. It is difficult by naked eye to find, but ultrasound, you can see a lot of membranous structures. So we have to suture such kind of superficial fascia in the fat tissues and close the wound. After that, finally we can start dermal suture. This is very important concept. So this is an example of abdominal surgery. So tumor removed, and the fat tissue is also removed and becomes free and undermine below the deep fascia. And at first, deep fascia should be sutured tightly. Then we have to suture such kind of membranous structure, superficial fascia. The superficial fascia can be found in the fat layer and sutured. You can see this is superficial fascia in the fat layer. This one. And after suturing superficial fascia, almost wound edge is attached. At that time, finally we can start dermal sutures. This is very important. And the close superficial fascia, superficial suture we do. So finally, in case of abdomen, 4 to 5 layers should be sutured. This is very important. So in case of face, maybe fat tissues and dermis and superficial layers, so 3 layers should be minimum. So in case of abdomen, the deep suture is very important. After suturing deep tissues, wound edge is attached naturally and gently lays. This is very important. If you find notch, this means suture dermis from the back side, from the internal side. So we have to cut suture, and again we try to suture fat tissues. Okay, and this photograph is immediately after suturing superficial fascia. So at that time we can start dermal sutures and superficial sutures we do. Of course, after surgery, taping fixation is very important. So 6 months after surgery, the elevation becomes a little bit flat and wound width is minimum. And 2 years after surgery, inflammation completely decreased and the maturation is completed. So similar case, the 1 centimeter width of scar, so remove and undermine pectoralis major deep fascia, and deep fascia is sutured, and superficial fascia is sutured, and almost the wound edge is attached. From now, we can start dermal sutures, and dermal sutures and superficial sutures, and this is the result 2 years after surgery. So in case of face, same situation. We have to suture fat tissues. So if you suture fat tissues and try to pull, and the wound edge is attached, it is good. So we sutured fat tissues, and after that, this is immediately after suturing fat tissues. After that, we start dermal suture and superficial sutures, and this is results. Actually, this is 18 months after surgery. This is a wound, and this is nevus, the same situation. So what tissues should be sutured? And maybe 2 to 3 millimeter from the edge, and below the fat tissue is sutured like this, and almost wound edge is attached. We do dermal sutures and superficial sutures. This is the result of 6 months after surgery. So same situation, the 3 millimeter scar, the remove and fat tissue is sutured using 50 and 60 PDS, and 70 fluorine, and 3 months after surgery, and 1 year after surgery. This is we sense the nodule under the scar. So remove, this is inflammation is decreased, but fibrous tissue exists. So remove everything and softly suture, and 6 months after surgery. So this is just a trauma, and this is elderly patients, so not so difficult, but important things is that we don't suture skin. At first, we have to do muscle, and we have to adjust the border, vermilion border, and inside oral, we do bicreal, and this is 2 years after surgery. They almost become natural. So this is skin cancer, same situation. The fat tissue is sutured. After that, dermis is sutured and superficial sutures. Okay, same situation. So older patient, skin is relatively relaxed, so much more easier than young female patients. So this case is skin cancer, so excisional biopsy and closed, and it was VCC, and the margin is positive. So again, we try to pinch, and the skin is relaxed. So again, we remove and suture. So this is 1 year after surgery. So this is abdominal scar. Well, everything is same strategy. Remove everything and undermine, and deep sutures and the superficial fascia sutures, then dermal sutures and superficial sutures. The shape of navel is also improved. This is a scar. So we have to consider the hard string will be produced by surgery. So W-plasty is very easy to release tension. So long linear hard string will not be produced by W-plasty. So the elevation becomes flat, and the less outstanding scar is produced. So this is this is a scleroderma, the localized scleroderma. So this line is the crease. The line is horizontal, but this line is vertical. So we have to do surgery carefully. But the segmented like this using W-plasty, and this line should be matched to the crease. And after that, we start dermal sutures and superficial sutures. So this is the result. This is scar. So 1 year after surgery. So same things. So Z-plasty is also fine. So 6 months after surgery. So I always use microadhesion, the very small pinch exists. So microadhesion, this is very easy to suture dermis and superficial fascia, and very minimum diamond the forceps, and number 11 knife is that I always prefer. And also, this is a magnifying glass for general public. So actually the Hazuki loop, this is a very famous loop in Japan, and magnificent is a 1.6 times, so not so high, but the nevus, for example, nevus becomes 1.6 larger, so it becomes very easy to suture. So such kind of magnifying glass is very important for skin surgery. So in case of C-section, the scar is less noticeable in the horizontal incision because the abdomen is also always the tension line is vertical. So horizontal cut is reasonable. So wrinkle, if you can find wrinkle in surgical area, you should cut align with wrinkle because the wrinkle is 90 degrees different from the direction of stretch. So this means RSTL, if you can see wrinkle, we should cut because the tension line is this direction. So this is muscle is exist here. So in this area, the cut like this, and in this area, we have to cut horizontally. Okay, so this is an ideal incision line that makes scars less noticeable. So joint always horizontal. And in case of chest wall, the tension is horizontal, so ideal incision line is vertical. But abdomen is horizontal because tension is vertical, okay? So next one is a post-operative care. So maybe you apply tape to prevent the wound from opening. This is not so good because tension of keloid, this is keloid, tension is this direction. So if we want to decrease inflammation of this keloid, we have to put tape like this. We have to put tape. So actually this tape is applied to prevent wound dehiscence. This direction is not always matched to the tension direction. So we have to apply tape to resist tension. This is very important. So even if we cut vertically, we have to put tape vertically in case of abdomen, okay? So even if we cut horizontally, the tape fixation should be vertical. So always you have to think about how to resist tension. So this is clearly different from to prevent the direction to prevent wound dehiscence, okay? So in case of chest wall, tension is this direction. So tape should be put like this. Even if you cut, please, even if you cut horizontally, you should put tape like this. So, but actually it is hassle to think about the direction in which the tape is applied. So the good idea is if the tape is not stretched both horizontally and vertically, the 360 degree, if we can fix it, it is reasonable and very easy to manage. So maybe other idea is that you can stick the tape in a grid pattern, but it is troublesome. The patient is not so easy. So if the tape will not be stretched both vertically and horizontally, just one tape is enough. So this is the scar management tape at fine. So you can use it without being conscious of the direction of sticking the vertical and horizontal. So this is maybe Chinese version. So maybe you can buy in Taiwan. And this is a tape specialized for wound scar care, okay? So this case is treated by tape. And you have a lot of choice: paper tape, silicone tape. And silicone tape is very nice because, but silicone tape is also not stretched to the vertical and the horizontal, but it is expensive. But the contact dermatitis will not occur. So maybe the silicone tape is better than atropine, but atropine is much cheaper than silicone tape. So maybe you can choose according to the economic situation. And of course, silicone gel is you can apply the same situation. Another advantage other than the cheapness of paper tape is the cream and ointment can penetrate. So if the patient senses itchy, maybe pain, so you can use steroid ointment or steroid cream on the top of tape. So this case was treated by tape and ointment on the top of tape. So actually, keloids are unlikely to occur in eyelid surgery. So in such area, the post-operative tape fixation is not required for wrinkled wounds. Okay. So no strong force is applied to the face. So post-operative tape fixation is not required for wrinkled wounds. So if the wound is matched to the wrinkle, the post-operative care will not be, we don't need to consider. But for example, such case, we don't need to do surgery. But if the patient suffer from vertical wounds, we have to do surgery. So this case was treated by just taping, no problem. So how long do you stick the tape? So we have to think. So we have to think the wound healing cause, and redness and the ridge confirmed 3 months after surgery. And many old textbooks mention that keloids and the hypertrophic scar is developed after 3 months after surgery. But this is a typical wound. So when we remove stitches, the wound is closed, and both patients and physician think wound is healed. So let's start to remove sutures. But actually, epidermis and dermis wound healing is completely different. So epidermal wound healing means such kind of keratinocyte migrate and close wound. Just it. So just wound closure is occurred on the surface. But dermal wound healing is much more complex, and it will take a long time. So not healed, actually. So both doctors and patients think the wound has healed in 7 to 10 days, but it is not good. So actually, dermis, fat tissues, muscle, still in the process of wound healing. So 1 month after surgery, the dermis strength recover 50%. And 3 months after surgery, it becomes 80% of strength. So at least 3 months, we have to do external support. Okay, so everyone think such kind of surgery, the primary healing is occurred, but actually the inside looks like secondary wound healing. So we have to care. So actually 3 months after the operation, and the inflammation of the dermis becomes little by little strength, and finally it's visible. So inflammation starts immediately after surgery. So we have to manage wound immediately after surgery, okay? So taping fixation for at least 3 months is necessary for normal surgery. And in case of face, maybe 1 month would be fine because the tension is not so strong. So actually the early detection and the early treatment start is very important. So if we find hypertrophic scar or keloid formation, we have to change to corticosteroid tape. In case of Japan, the steroid tape is a first-line therapy. So maybe in Taiwan, it is difficult to use steroid tape. So in case, just such cases, maybe steroid cream or steroid ointment you have to use. So in Japan, strong tape and a weak tape we can choose. And in case of children and older patients, the skin thickness is thinner, so weak steroid tape would be fine. Everyday patient use and change tapes. And 6 months after surgery, 26 months after treatment, the little by little inflammation decreases and becomes flat. At that time, I told to the patient, please use tape, just this lesion. And 26 months after surgery, 26 months after treatment of tape. So, but adult patients, it will take longer with hydroxychloride, the weak steroid tape, it took 3 years. So in this case, strong steroid tape I prefer. So ecra plaster, this is very, very easy. And 1 year after starting treatment. So it is similar case, the similar case. 3 years after treatment, ecraplaster patients change every day, and the inflammation decrease, and the pain and the itchy will decrease 3 months after starting taping fixation, taping ecraplaster, and 3 years the inflammation almost gone. And this case is also treated by just tape. This case is also treated by just tape. So just 2 months would be fine for such kind of minor inflammation. So in case of injection, of course, patients come to the hospital, we can combine such kind of injection. So the injection should be target is peripheral area, because always the inflammation is strong on the peripheral area. So peripheral area should be target. And if you inject into the hard mass, the pain increase, so you shouldn't do that. So if we can continue injection and tape, it will be healed. So advantage of steroid injection is fast acting. So for difficult keloids, combined treatment is necessary. So keloid looks like a burning house because inflammation, very strong inflammation. So repeated stretching looks like adding fuel to the fire every day. So our methods, operation, radiation, and lasers and creams. So case by case basis we have to use, but very strong inflammation, we have to do operation sometimes, and radiotherapy is also good. And after that, inflammation decrease, we have to change such kind of modality. This fire will not be completely decreased by surgery, because after surgery, very weak inflammation start to heal. So this inflammation we have to manage by steroid and lasers. It is very important. And scar becomes visible. Next step is operation, fraction laser, and makeup therapy. So I'd like to share my cases. This is the primary radiotherapy. So please understand keloids, and keloids is inflammation. So if we do radiotherapy, the blood vessels is damaged at first, so color is changed. After that, collagen is decreased and becomes flat, and the maturation completed 18 months after treatment. So clearly, the radiotherapy works for keloid, but of course, we have to consider about secondary carcinogenesis or side effect. So the target should be an older patient, not sensitive against radiotherapy. So primary, this is also primary radiotherapy. And this is a surgery and post-operative radiotherapy. Remove and fascia sutures and radiotherapy. Same case. And the W-plasty, so this is keloid. So remove and defasciate sutures and Z-plasty. So three-dimensionally, tension should be removed, and taping fixation is also necessary, and radiotherapy is necessary, and 2 years after treatment. and 18 months after treatment. So similar case, zigzag sutures and deep fascia sutures and zigzag sutures. Same case. So similar case. Of course, such kind of keloids cannot be treated by steroid tape. So remove and radiotherapy. Similar case. So similar, this is trauma keloids. This is scar. Similar case. And in case of skin graft, such kind of burn hypertrophic scar, we have to do skin graft, but always we have to do full thickness skin graft for aesthetic reason, because full thickness skin graft can release tension after surgery. But in case of split thickness skin graft, secondary contracture occur. So hypertrophic scar recur. So this is a result of full thickness skin graft. So local flap is a very powerful tool to release tension. So transposition flap is very nice. So skin pedicle can release tension effectively. So this case, very stiff area is removed and the flap is transposed. And this skin pedicle release tension and the inflammation decrease and the maturation is accelerated. So this is keloid. The skin pedicle here, skin pedicle is here. So this skin pedicle can release tension effectively. The tension line is this direction. So flap should be designed like this. So this is square flap method. So this is a combination of square and triangular flaps. This flap comes here, this flap comes here. So please look at this. The stiff area is removed and this flap go ahead this here and this flap comes here, this flap comes here, immediately after surgery. And 1 year after surgery, you can realize the square shape becomes triangle. This means skin pedicle release tension effectively and tension released. So inflammation stopped and the inflammation decreased and scar is matured. Okay, so this is square flap method. Immediately after surgery, already the skin is stretched and elbow is stretched. And 18 months after treatment, please look at this. Maybe 2 times longer than initial square. So in our data, after the surgery, each skin pedicle released tension and elongated. And finally, tension reduction rate is 3.24 points. Very effective. But this is very severe case. The joint cannot be removed. And the systemic keloids with diabetic patients. So it looks like burn reconstruction. The flap is used like this, and the remaining contracture is released by square flap method. And finally, radiotherapy is performed. And this is 1 year after final treatment surgery. ROM improved a lot. And for cartridge part of ear, the just core is excised and the flap is sutured softly and radiotherapy. And just core is excised and flap is made on the keloid because the keloid is inflammation of reticular dermis. So just reticular dermis is removed and the flap is sutured and radiotherapy. Okay, same case. Ingrown nail keloids. Also core is excised and radiotherapy. And in case of piercing keloids, just wedge excision would be fine. Same case. And sometimes we do laser because a vascular laser is effective to decrease blood vessels. Always inflammation is coming from blood vessels. So if the number of blood vessels decrease, the inflammation becomes weak. So the indication is thin keloid, thin and red keloid. And sometimes we do steroid, such kind of telangiectasia occur. So such kind of blood vessels can damaged by laser, and this is 3 years after treatment. So relatively thin type hypertrophic scan keloid is the target of laser therapy. Inflammation becomes weaker. And of course, combination with steroid tape is better. And the fractional laser, we have used several devices. The minor bumpy surface can be treated by fractional laser. This self-harm injury scar. So finally, makeup therapy I'd like to introduce. This is a very thin tape, and on the top of thin tape, we do foundation. We put foundation. So both color match and the texture match can be improved by these methods. So even if patients are under treatment, the patient can make up by herself and go outside. So mentally, patients improve a lot. Similar case. So please understand the main treatment for scar in Japan is now control of tension and inflammation. And I have mentioned for general clinic, please use steroid tape and plaster at first. At least please use 3 months to 6 months. And if it doesn't work, please send patient to our hospital. Because we are specialized clinics, so every kind of treatment we can do. So please try steroid tape at first, and then please send patient to our hospital. I have mentioned to the clinic doctors. So please understand now, even severe keloids can be cured almost completely. So main treatment is a surgery, radiotherapy, and steroid tape plaster in Japan. So we always welcome visitors from all over the world. So if you have interested in, and if you have a chance to come to Tokyo, please stop by our hospital. And everything is written in this textbook. This is Japanese. I wrote by Japanese. So, but maybe you can read Chinese characters. So, and mainly I written by graphics. So maybe if you have a chance, please read this Japanese textbooks. And also, we have published Total Scar Management by Springer. So if you are interested in our methods, please look at these textbooks. And also, this December, the G-SCARS, the most biggest scar conference in the world, will come to Japan. Unfortunately, the COVID situation, we cannot invite foreign doctors, but this will be delivered on demand. So please join if you are interested in. So I'd like to conclude my talk. Thank you very much.
Thank you, Professor, for your excellent talk. And we also learn about lots of knowledge and the management of keloid.
Yeah, thank you very much.
Is there any question from the audience? Maybe I think Professor Yang. Professor Yang, would you?
Oh, hello.
Yes, Professor Yang.
Can you hear me?
Yes, we can hear.
Oh, thank you. Dear Professor Ogawa, good evening. Every time here lecture, I enjoyed it very much. And
thank you very much.
Knew something different. Yeah, your achievement is very great, very good. You can control the keloid very well. Congratulations. Did you have experience to do surgery for the young children or even kids and then followed by irradiation.
Yes, so for
Yeah.
children, radiotherapy should not be used. So in that case, for children case, that we do just steroid tape and ointment. So sometimes the children, the very severe keloid is developed. So such cases is very difficult to treat. But maybe the radiotherapy we shouldn't use. So another method we have to select. Okay.
Another question is I just forget the children is very difficult to handle because they cannot cooperate with us for the post-surgery care, including jobs that I mean pressure garments or even
Yes.
print. So it's this kind of situation always make me very trouble. How do you do this post surgery physical therapy for the children? Do you have a good method, good idea?
Yes. So for rehabilitation, so rehabilitation is good for joint, but bad for scars. So inflammation should be decreased by steroid tape. Yeah, in case of Japan, steroid tape is applied and moved. So inflammation is decreased by steroid, but joints should be moved by rehabilitation. So both things we have to do. So both steroid and rehabilitation, we have to do simultaneously. Yes.
Yeah, like a steroid tape, I think it's very useful. I have also another third question. Is that all right?
It's all right.
The scar keloid, your pathological finding, your explanation is very good. Also, the direction of the scar. That's one reason I think it's very important. But I think hormone patients hormone. I mean like young boy or young adolescents when quickly development. That time, for example, about 10 years or so for young children, seems more easily to have keloid tendency and more difficult to control. Do you have this kind of feeling, findings?
Yeah. Yes. About
Yes.
sex difference, actually the female has a high risk compared to according to our data, 3 times the
Yes.
female, the incidence is 3 times higher than boy. So actually the estrogen is a risk factor for severe scars. Inflammation easy to continue according to the estrogen because estrogen can dilate blood vessels, so increase blood flow. So
Yeah.
estrogen and the pregnancy is a risk factor. Yeah. So systemic factor exists.
Yes, thank you. I also try to do big surgery for those adolescent female, especially female. Thank you.
Yeah, thank you.
Thank you, Professor Yang. And maybe our boss, Professor Law, has also some question want to ask Professor Ogawa.
Thank you, Professor Ogawa, for your very nice lecture. I'm my profession is to do credit repair, and we always try to reduce the lip scar.
Yeah.
I learned from one of my colleagues, Professor Frank Zhang, that after the lip repair, we use Botox injection to
Yeah.
reduce the lip movement in order to reduce the lip scar.
Yeah.
And also, in addition to this, when we remove the stitches, we use lip taping across the lip skin area. I don't know what addition management you can suggest that we can use apply to reduce the lip scar.
Yeah.
Usually the patient is three months old baby.
Yes. So inflammation after surgery, lip surgery, the inflammation little by little becomes stronger. So I think if the patient is in Japan, the steroid tape, we use steroid tape. But if you cannot use steroid tape, maybe steroid cream every day you have to put, and the inflammation decrease. So please try. And also the taping fixation is very important. And maybe, as you mentioned, Botox is also very effective if you inject into the muscle. The some paper, the Botox is injected into the scar. So I don't know what will be happen, but if Botox is injected into the muscle, it will be reasonable, and the tension will be decreased and the inflammation decrease, I think. The steroid, maybe, yeah, please try.
Yeah, thank you.
Yes.
Thank you, Professor Low's comment. And then maybe our best friend, Dr. Xu Xiaokai, maybe she has also comments.
Yeah, thank you to the Ray for a great talk again. And here we can check our message board. And the one question is from Dr. Tisia Watdini. She would like to consult you about the details of the tips and trick to treat the keloids on the ear. Thank you.
Yes, excuse me, ear?
Yes, the ear keloid. Of course, you have shown some very nice cases already. However, it would be great if you can talk more about the ear keloid.
So actually, ear keloid is the cause of inflammation. A cause of keloid is of course the piercing, and the inflammation becomes little by little stronger. So maybe in case of piercing, the piercing hole, internal lumen of piercing hole is epidermis. So epidermis is closed, and this looks like a epidermal cyst. There's sometimes inflammation increase and keloid is developed. So if the infection is also maybe sometimes caused, so such kind of case, that area should be removed. And in case of earlobe, the skin is still available on the cheek side, and the piercing hole becomes larger. So skin can be used next to the adjacent to the keloid. So in case of earlobe, just remove everything and just suture would be fine. But the cartilage part, if we cut wedge excision, the cartilage shape becomes different. So just coils exercise. And coils exercise, and at that time, as much as we can, we remove hard mass, and epidermis and the papillary layer of dermis is remained in the flap, and the flap is sutured softly, and after that we do radiotherapy. Is it okay? So we have to consider the different differently, we have to think about the cartridge part and yellow. Okay.
Thank you very much. And Professor Yang, you has also want to.
Yeah, I would like to. Can you hear me? Okay. I have some experience about the ear keloid. As Dr. Professor Ogawa said, many cases of the ear keloid resulted from urine pigeon, and maybe involved some infection or some repeated damage. So from that area, pigeonhole developed into a big keloid. In this situation, intrascar steroid injection is cannot achieve good results, and very difficult to put a steroid injection. This time, I always do intrascar excision. Sometimes you have to leave some keloid tissue for wound closure. And the underlying keloid structures are removed as much as possible. Then reduce the volume and followed by steroid injection, maybe several weeks later. Within 1 month, the young keloid is more easier to control, and you have to explain to the patient in this this situation need steroid or even irradiation follow up the surgery. The surgery I called it intrascar excision. If you can leave some healthy skin, it's not good. It's very good. If cannot, just leave some keloid tissue, superficial keloid tissue for wound closure. Then within 1 month after wound healing, start keloid. It's very easy to control. That's my experience. Thank you.
Thank you, Professor Yang, the very kind answer for about your experience. Thank you very much. And let's back to the audience question. And one question I think it's quite interesting. It's about the systemic control of the inflammation. So I think right now more and more people would like to treat the very severe extensive keloid. For example, like the very recently in JADV showing the dupilumab, the therapeutic response, it's a Th2 inhibitor. So I think it's a very good question from the audience. It's Dr. Duby asked about the question is so Ray, do you have any suggestions or recommendation for the control of the systemic inflammation for the keloid patient? Thank you.
Yes, so sometimes every folliculitis becomes keloid and the inflammation is very strong. So such kind of patients exist. So in that case, we recommend intraoral steroid treatment. So after 3 months starting, the inflammation decreases little by little. So it becomes much easier to treat. Or maybe let's discuss after we talk with patients extensively, sometimes patients do exercise or something, the hard work using body. So such cases, inflammation becomes stronger and stronger. So at first, we have to talk with patients. What are you doing in every daily life? And if such kind of the tension is not so strong, So maybe systemic factor we have to consider, and the hypertension, estrogen, and much more the inflammatory cytokine issue I didn't talk today, but a lot of systemic factor exists. So one by one, we have to discuss with patients. And sometimes we do oral therapy, oral steroid therapy, or maybe steroid tape is used large area, and a case by case basis, we have to treat with discussion with patients. Okay.
Yeah, thank you. Thank you very much. And any more questions from the audience?
Junior.
Okay. Actually, we have a lot of questions from our audience, and so we'll just quickly go through them. Also, Dr. Steinberg would like to ask Professor Ogawa whether there's any role in massage or pressure application.
So massage for inflammatory scar is not good because tension is arise and inflammation becomes strong. But compression is very good because blood vessels is compressed and the blood flow decrease. So inflammation decrease. So compression therapy is very reasonable, but massage is not good for inflammatory scars. But at once inflammation decreased and almost matured, scar becomes matured, massage sometimes work. So inflammatory scar, you shouldn't do massage, okay?
Okay, and we also have questions from Dr. Vita Dewey, and asking, is there any specific size of post-excision for which the keloid is fine with primary suture instead of local flap? So would you define
Yes,
like
so,
a specific size?
Yes, it depends on the body side, of course. So please try to pinch, and if you judge it can be closed, you can do that. But it's very difficult to pinch, so you have to select local flaps. But sometimes judged local flap is necessary, but after excision and try to defasciate sutures, maybe sometimes can be closed. So maybe both before surgery, we plan both direct suture and local flap design, we plan and do surgery, okay? But the pinch the skin, it is very important.
Then we have Dr. Hassan, who would like to ask you whether the usement of thermal abrasion and STSGs in post-burn patients would help with like hypopigmented scars.
Yes, I think so. Dermabrasion, if it is not inflammatory scars, dermabrasion may be good, I think. So you can try. But inflammatory scars, you shouldn't do that because the inflammation becomes strong. Okay.
And Dr. Hassan would also like to have a follow-up question on whether how long you would recommend the use of the taping closure after your operations.
Actually, high tension area in case of chest wall, I recommend patient at least 6 months to 1 year. In case of face, just 1 month. So it's depend on the body side. So always you should touch the scar, and whether you sense stiff or not, it is very important to stop taping fixation. Still stiff, you have to continue to use tapes. It is very important.
Okay, thank you, Junior. And maybe Junbin, you can ask one more question. Or
okay, thank you, Professor Ogawa. Thank you for your wonderful talk and very amazing cases presented.
Thank you very much.
According to previous questions, you mentioned that inflammation is very important. And so for a case that just exists, operation, do you think an immediate anti-inflammation or some immunosuppressants adjuvant would be appropriate, since that we know that during the acute stage of wound healing, this inflammation are also very important for a good wound healing. So do you think when will be the most appropriate time for this kind of agents, such as intralesional steroid use, or adding on some immunosuppressants such as corticosteroid?
Yes, I think the 2 to 3 weeks after surgery, you can combine, I think. So, but 2 to 3 weeks, you should wait. So in my case, the steroid tape is applied for prevention purpose, but after 3 weeks surgery, 3 weeks after surgery, we start steroid tape, and no problem at all. So, but we don't inject, but yeah, steroid tape, in case of steroid tape, the 3 weeks, maybe immunosuppressant or something, if you want to use, 3 weeks, you have to wait. 1 month is safe.
Thank you, Professor. And and also there are so many questions. Sorry. And from Dr. Punit Dubey, and he asks, how long should be the application for taping in 24 hours? And can compression garments replace the need for taping? And also he also asks, can we use oral medication for reducing inflammation and do placement of suture in fat layer cause atrophy of fat?
So if this means tape means the paper tape or silicone tape for fixation,
yes,
can continue to use until naturally detach. Because every day, if the patient detach and put the dermis, the epidermis is injured and becomes red and painful. So you can continue to use until it will be naturally detached. But in case of summertime, the sweat increase, so difficult to use. But naturally detached, we can change.
Yes.
Okay, but the steroid tape, every day patients have to change.
Yes.
Because the concentration of drug decrease 24 hours.
Okay. And also he asks the second question is for when we do the fat layer sutures, it will cause the fat necrosis or not?
Actually, no.
Actually, no.
Yeah. So the fascia, actually fat lobules should not be sutured. Actually, the deep fascia and superficial fascia should be sutured. So if you suture very largely, including fat lobules and muscle, maybe necrosis occur, and the wound dehiscence occur, SSI occur. So minimally, the fascia should be sutured, fine and sutured. Okay.
Okay.
It is important.
Okay. And also one question is, do you think we can achieve better results with tissue glue? It means we can use
tissue glue.
Yes.
Yeah. So if the deep sutures is perfect and the dermal suture is perfect, you can use glue. But the result will not so changed compared to 6-0, 7-0 superficial sutures.
Yes, yes. Yes. And also Lena Ho asks, when to start radiation therapy after surgery incision of the keloid as your standard, and how to quantify the radiation dose? Okay.
So we have published a lot of papers about radiation protocol. So actually the question about the starting time point of radiotherapy after surgery is, in my opinion, any time would be fine if it is during 2 weeks after surgery. But in my hospital, if we do surgery on Friday, the radiotherapy will start next Monday. And if we do surgery on Wednesday, next day, Thursday, then we start radiotherapy. So 1 to 3 days after surgery, we start in general, but any time would be fine in my experience, if it is during 2 weeks after surgery.
Okay. And also Mark Lin also asks you for the as for co-incision you mentioned to remove reticular dermis to decrease inflammation, and how do you discriminate reticular dermis from papillary dermis on gross inspection? How compromise circulation of the skin envelope develop through this procedure?
So actually, it is easy to see, it is easy to judge this is reticular dermis and the papillary dermis. Actually, epidermis is very easy to find, and reticular dermis is very easy to find. So between 2 layers, you can see the papillary dermis, so you can see. But of course, the keloid co-excision, if you plan, so it is very difficult to remove just core. So as much as you can, you remove hard tissues and sutures and the post-operative care you have to do. Okay.
Yes, and because when I doing study in Nippon Medical School, and you have to do the co-incision. So I think maybe the flap, you elevate flap about maybe 1 or 2 millimeter is okay, and the skin envelope, the circulation is very nice, because also post-operatively the skin will become blue, but it's okay because when 2 weeks later I remove stitches, the skin is okay, the circulation is well. Because I think from the ear, the circulation is very well during the surgery. Yes,
I think so.
Yes.
Thank you.
Thank you.
Okay, thank you, Professor Ogawa, and thank you for all the panelists, including Dr. Xu Zhaokai, Dr. Chen Junbin, and Dr. Tai Jiaxuan Sensei. Thank you, Professor Ogawa, again, and thank you for the comment from Professor Yang and Professor Lunzhou Lou. I would like to say again and pay my utmost gratitude for our Professor Ogawa. You teach us a very important lesson today, and we learned really a lot. Actually, 6 months ago, we already invited Dr. Jiaxuan Cai for giving us one of the best lecture, including just like the topic the same as yours, the keloid treatment for us. So today is we are so happy to have Dr. Cai's mentor from the Nippon Medical School and University in Tokyo in Japan for us. So it's our great honor to have you with us tonight, actually tonight and or this morning. Thank you very much, Professor Ogawa, and I hope one day you can give us another lecture, and we hope can invite more and more audience, and I think all of the audience is all of your fans. Yeah, your chapters, your textbook, and your lectures. Yeah, we all learn from you a lot. Okay, so I think Professor Ogawa, should we have a little time to have a group photo with all our participants together? Okay, so I hope all our audience can show you a smile with us, and please open your screen.
Yes, okay.
Yes, yeah. Okay, so I would like to.
That's all right.
Yes, yes. Oh,
Thank you.
Wait. This is the professor. Okay, so please show your smile, and I will count to 3 to cheese, and you can give me a cheese. We have a 4-page of the audience. So from the first page. Okay, 1, 2, cheese. Thank you. So I would like to go to the second page. Yes. Hello, from the Team Mola. Okay. Count to 3. Cheese. 1, 2, cheese. Very nice. And we proceed to the next page 3. 1, 2, cheese. Thank you very much. Okay. Good morning and good night. Thank you for your participation in ICC with us, and thank you, Professor Ogawa, again. See you next week.
Thank you very much.
See you.
Yeah. Thank you very much.
Bye-bye.
Bye-bye.
Thank you.
Bye-bye.
Bye.
Thank you very much, Professor.
Thank you,
Yeah.
Professor Ogawa.
Yes, thank you very much, Professor Ogawa. Yes, thank you very much. I will make my video record for the G-Scar. Also, Zhao Kai, you also need.
Yeah. Okay.
Okay. Thank you
Thank
very
you.
much.
Bye.
Thank you. Bye bye.
Thank you. Bye-bye.
Bye bye。
Bye.
哎，赵凯学长，你的那个 CV，哎，学长，你声音没有开。啊，学长跑掉了，好，我等下再问他好了。
好，谢谢。Thank you, Dr. Fayaz。谢谢俊斌，谢谢俊佑。
谢谢俊斌。
OK。
好。
Have a good night. Have a good day.
拜拜。
拜拜。
拜拜。